Hello, everyone, and welcome to this episode of Cracking Addiction. And once again, we have with us the good Mr. Stephen Hurd. Hello, Stephen. How are you?
Yeah, I'm really well, Ferghal. How are you today?
I'm pretty good. So I thought today we'd continue our discussion on family violence by talking about the evidence-based risk factors for lethality. Can you tell us what that concept is before we start delving down into those individual risk factors?
Yeah. I guess over the decades, there's been a lot of emphasis put on are there a common set of characteristics that we can identify in research that give us some indication that a male partner may kill or nearly kill his female partner. And over the years, as we know, the prevalence of homicide, intimate partner homicide, there's about one woman who's killed per week by her current or former partner. And there's a growing evidence base as to the trajectories of those relationships and how they turn out and the factors associated with them.
Yeah.
And up until about 2010, 2013 or so, there was a set of factors that were developed, identified, and consolidated into what was called the Common Risk Assessment Framework. That was about 2010. And they identified a range of factors that they were able to say were either a high risk factor for lethality or a standard risk factor. With the advent of MARAM since 2016, that list has been added to with a few more in terms of the children's experience in particular, and a couple of other situational type factors. So what that means is if we identify some of these factors in a victim's story, in their experience with family violence from their partner, then each of those factors accumulate and increase what we would say is the risk that she could be killed or nearly killed. Does that sort of give a reasonable background?
It does. I think, and I suppose the discussion also brings into sharp relief the idea that actually, more than one woman a week in Australia is killed by a current or former partner. And that in itself is a shocking statistic. And I suppose really it also highlights the relevance of what we're talking about. So this is an issue that should affect everyone in society. We should all be aware of this basic truth. And I suppose this is a useful segue into what are those risk factors. So I have a list in my head of what I think the high lethality factors are. I suppose we can go through each one and we can talk about them. But firstly, for me, one of the most important ones is a pattern of escalation of violence. What would you say to that?
Yeah, and that is an identified risk factor. And it's known that violence towards women from a partner can escalate. Those elements of control that might start off early in a relationship, the man seems to need to use more and more techniques or the severity of it to be stronger and stronger in order to get the control over his partner. And the partner's probably becoming more au fait with how to manage that over time and is developing their own strategies to counteract it and resist it. And then that in turn builds on him to express his desire to control her using more significant ways. I guess if we can talk pretty basically around what physical violence might be, physical violence might start off as a slap. Innocuous, I guess, as a standalone item, but the type of physical violence can change. We can all envisage different types of things happening. A slap goes to a punch punch goes to a significant push over a couch. And what's being identified as probably the most significant physical risk factor is strangulation.
That was second on my list.
Right.
Yeah.
And
yeah.
that and you in me in family violence terms, I identify that, and that is a really significant high risk factor. But in medical for family violence, but in medical terms, if you want to elaborate on what the medical risks are around that.
Oh, it's huge. So there's a number of things to say about choking. First of all, in my experience, victims of family violence don't ever say that they've been strangled. And if you ask the question, has your partner ever tried to strangle you? The answer is invariably no. But what they might say, or what they might answer to the affirmative, would be the question, has your partner ever put his hands to your neck? Because they don't identify with the word strangulation. So that's the first point I'd make to that. The next thing to say is the strength of the grip that is required to lose consciousness during an attack when someone puts their hands around a victim's neck. That grip strength is no greater than the grip strength needed for a firm handshake to cause loss of consciousness. Now, the next thing to say beyond that is that it only takes 15 seconds of strangulation with a firm handshake grip strength to lose urinary continence, and only 30 seconds to lose fecal continence. And of course, women who are the victims of family violence, they, because they've lost consciousness, they first of all, they'll minimize what's happened. So they'll say, yeah, he put his hands around my neck. Then they'll blank out. So they lose consciousness. They can't remember. But then they'll remember waking up, having either wet themselves or soiled themselves. So when I'm asking about this question, or when I'm probing about this question, I tend not to ask, does your partner strangle you? I ask, have you ever had your partner put his hands around your neck for whatever reason? And have you ever woken up slightly disoriented, having wet or soiled yourself? Now, that in and of itself is a risk factor for lethality, but it's also a risk factor for significant morbidity, because you've got to remember the structures around the neck are very fragile. So you're squeezing the arteries to the brain, for one. And so you can cause damage to those arteries, and that damage may not be apparent for many months. So really, it can be strangulation in the context of intimate partner violence can actually be a risk factor for stroke. So one of my differentials for someone who presents with a stroke, who's young and female, and possibly the victim of family violence, is strangulation. The other thing to think about is you've got a very fragile gland at the front of your neck, just around the Adam's apple, called your thyroid gland. And if you squeeze your thyroid gland, you release all of these hormones, you can end up with clinical hyperthyroidism, and that can cause problems. And then, of course, you can have structures, you can damage the cartilage and you can damage the voice box. So there are a number of morbidities, illnesses that can be associated with it, and it's a high risk factor, and it's under-recognized, and it's underplayed. The significance of it is not really appreciated, both on the part of clinicians and also on the part of victims of family violence.
I've not been aware of the incontinence aspect, and it's and that is observable, obviously, to a victim.
Yeah.
Perhaps in a shaming sense, it might be really awkward, difficult to talk about. So you may not still get an appropriate answer.
You have to know the questions to ask. And as I've said before, people don't say, yeah, my partner tries to strangle me. It's very rare that actually presents.
What I have heard, and I guess my mental picture of strangulation is I guess we don't want to focus on this too much,
Yeah.
but I do have a question. Is two hands equally around the neck? But what I probably hear more often, just reflecting in my experiences, is a statement like, he held me up against the wall.
Yeah.
It's sort of like more of a one-handed kind of thing.
Yeah.
Is it?
Yeah.
I don't know. Is that it? Is there any difference?
Well, I suppose I don't actually think so. I don't think there is a difference.
Probably
But if you're talking about the mechanisms of loss of consciousness, all you need to do is to squeeze one of the arteries, and you'll create loss of consciousness.
Yeah. And the other thing I do know about the medical response is if we hear that a client has been strangled, or if she discloses that she has, then if it's within even if it's within a couple of weeks of the incident happening, is to still seek medical advice. Go to the GP and get checked out.
Yeah, certainly you'd need to be checked over. There are a number of things that I would worry about, including risk factors for stroke, risk factors for airway, and risk factors for thyroid.
Right. So is that sort of 2-week period? Is that a valid time frame? Or
look, I think I don't believe that we should put a limit to it. I think any victim of family violence should always seek medical attention at any time, because I think if you start saying, oh, within the first 2 weeks, then that puts a barrier up to actually accessing help at any time. So I wouldn't actually want to put a time frame to it.
Fair enough. So that, to me, that is a significant risk factor that may or may not be disclosed, and you use methods to ask in indirect ways or get indirect evidence that helps support that. And I guess that's sort of, we'll talk about the risk factors, but that sort of helps position what a family violence conversation sort of generally is anyway. A lot of the time is asking for indirect evidence, and I guess that's what these risk factors sort of point us to as clinicians. That ultimately we've got about 25 of them. The vast majority are what we call high risk factors, and then the rest are standard risk factors. And so, me as a clinician, what I want to do is get used to that list, and then as I hear a story unfold, as I use my normal everyday sort of interpersonal micro skills around just listening and reflecting and summarizing and validating, open questions, the typical interpersonal skills that we learn as counsellor types, is to build a story and build that set of evidence and really have those flags go off in the back of our head. I guess what used to be called red flags. That was a really common phrase through the 2010s, I guess. We'd hear these red flags. That's what a clinician might say. And that relates to this idea of, we've got these evidence-based risk factors. And they're called evidence-based because each of them does have an evidence base around it.
Yeah. So these are very powerful predictors of an elevated risk.
That's right. So there has been research put into it, and there's reviewable relationship correlations around this factor and the outcomes.
Let's talk about stalking. That's another evidence-based risk factor for lethality, isn't it?
It can be mixed up in controlling behaviours, obsessive behaviours. Both of those are high risk factors, and the general category of controlling behaviours is a high risk factor. And as we've talked about before, the definition of family violence is, or the purpose of family violence is around power and control, is having control over the other. So being controlled in whatever way, and that includes receiving all these text messages, perhaps.
It does, yeah.
It includes post-separation when there might be intervention orders in place and they're not living together anymore, and it could include physical stalking, and that's what I guess we imagine when we hear that word stalking.
Mm.
But there's also
But
cyber stalking as well.
yeah, it's important to appreciate the extent of stalking because it's not necessarily standing outside someone's bedroom window at 4 o'clock in the morning taking photographs of the new boyfriend's car, a number plate. It is a range of behaviors, which does include harassing text messages. I've had
Absolutely.
patients who say they've had 300 text messages a day. I mean that's
and yeah, just continual phone calls. Where are you? What are you
yeah,
doing? Who are you with?
yeah,
There may
yeah,
not be those direct questions, and a victim in that certain circumstance may not identify it as well.
yeah.
They might report, well, he loves me.
It's attention.
Yeah, and he just cares about me.
Yeah.
And he tells me I can't look after myself, and he's right. And so this is his way of showing his love. So that interpretation is something we continue to grapple with, and whether it's a real interpretation or what's the impact of that particular person, that woman having that interpretation on her choice around what she's doing. I heard a really interesting scenario the other day, first time I've ever heard it. What we might typically see in a session is a female client. There might be a male partner sitting outside. Now we've interviewed the client separately, but she might get text messages saying, "What are you doing? How long are you going to be?" That kind of thing. Know what you're referring to. An interesting flip on that I heard the other day was there was a male client, and he exhibited in his known narrative controlling behaviours. But through the session, well, his partner, female partner, was out in the waiting room. But from what I understand, through the session, which only went for half an hour or so, he left about 4 times just to go and check up on her. So we could say he was going out to get support. He was doing something, getting a drink. But it just tweaked my mind that it could be that reverse sort of.
Yeah, he's
sign.
checking up on her.
So if she's still there, I need to. She can't be in here. I've got to go out there. Maybe it's a security thing. I don't know. But these observations, I guess the point is I'm trying to make is these observations of what we see, how we interpret them is really important. And developing a strong family violence lens with the backing of the evidence-based risk factors will give us a really strong knowledge base and clinical base to get a good formulation as to what the risk might be for our client.
Pregnancy. What do you think of pregnancy as a risk factor for family violence?
Again, another high one. I think the technical sort of relationship with pregnancy is if there's been physical violence while pregnant. So not so much being pregnant. I think in what I called the CRAF earlier, about 10 years ago, I think pregnancy was identified as a risk factor. In the Marin version of the risk factors, it's more associated with physical violence during pregnancy, and any sort of rational person would be really disturbed that there could be physical violence during pregnancy. And so probably a very clear risk factor. And the whole idea of the pregnancy and birth, the thinking around that is, well, the female's attention is now going to herself and going to her unborn child. And then when it is born, is obviously going towards the child itself, which it needs to.
Yeah.
And then there's that disconnect the partner may feel that he's now put in the background. He's being shown this child is now taken over.
Yeah.
So that in itself, when we sort of raise that kind of scenario, sends shivers up my spine. And so one of those situational factors of pregnancy, of having a client who's pregnant, really does add to the potential risk.
Yeah, I mean, reflecting also in the AOD space, pregnancy really is a factor that makes me try and do everything I can to get a patient treatment because, ongoing AOD use or substance use during pregnancies, it harms mum and it harms bub. So really, you're having to look after two people. Yeah. So listen, on that sweet note, we've run out of time today. So I want to thank you for your expertise, and I would hope that we can continue our conversation in due course. Thank you very much, Steve.
Thanks, Ferg. Pleasure.
That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.